Hey guys, it's Jason Auerbach, founder and co-CEO of Max Surgical Specialty Management, founder of Riverside Oral Surgery. We have 22 locations in the Northeast, and we're currently growing in 4 states and more to come. You may also know me as BloodyToothGuy, or BTG on Instagram and the rest of the social media world. Nice to be here. So I built my practice and my reputation on patient experience, and a lot of that has to do with direct investment into the best materials and best technology that's out there. Obviously, surgical instrumentation is the key to making the surgery as easy and efficient as possible, and of course as painless as possible for the patients that we see. It's very, very important to focus on not just correct technique and being trained well and being able to handle all possible complications that should come your way, but it's really important to have the armamentarium in your hands that are going to allow for you to perform procedures in the best possible way. When we're performing procedures, namely surgical extractions, we start out, of course, with a very good local anesthetic technique and progress using a periosteal elevator to elevate the soft tissue as carefully as we possibly can, paying attention to treat that soft tissue as carefully and kindly as possible so that when we finally close, we have very good approximation of wound edges. So first we use a periosteal elevator to elevate the soft tissue. We use a number of different elevators depending on the specific situation that are made specifically for the teeth that we're looking to extract, to displace the teeth, move the teeth within the sockets before we use a forceps and we actually remove the tooth. Typically, we're not using a forceps to force the tooth out. Typically, the forceps is only used once the tooth has been loosened. There's enough mobility created when we take the tooth out to just remove the tooth from the socket. Once the tooth is removed, we pay careful attention to debriding whatever is in the socket, whether it's infection, granulation tissue, or just periodontal ligament. We irrigate aggressively before we graft bone. Typically, we're using an allograft. That allograft is human cadaveric allograft particulate, and we place it in the socket, a carefully cleaned socket, before we use some sort of collagen membrane to close over. Then, of course, we use a figure-8 suture or some sort of interrupted suture to actually close the socket. We allow for secondary intention, and we create a very good bed into which a dental implant can go 3 months later. So most of the time, my use of extraction forceps comes toward the end of the actual procedure. Basically, forceps are designed for individual teeth or with individual teeth in mind. So let's say an upper anterior tooth would have a differently shaped forceps than would a lower premolar or a lower molar. Ultimately, when you're building an office or when you're trying to stock your office with the proper materials, it's important to have a variety of forceps because you're going to run into a variety of different teeth that you're going to be extracting, and it makes the most sense to be prepared for any tooth that comes your way. So there's always a question about what forceps should be used for someone who was not necessarily formally trained. You'd look online, you'd Google it, you'd look at a catalog, and you'd try to figure it out, or basically through trial and error, just using the wrong forceps in an inordinate amount of times and not getting it right and learning by kind of getting it wrong. Or you find a company like TBS Dental, which makes a Frings line of forceps that actually indicate on the forceps for what tooth they were designed. Makes it much easier, takes the guesswork out of it, and really just makes your whole patient experience much more efficient, and for you, much easier, much quicker. So much like forceps, I mean, trying to figure out the right elevator to use in each situation is something that a lot of, let's say, surgically minded but maybe inexperienced or less experienced dentists wrestle with. And what I did was worked with a company like TBS Dental and actually designed and figured out the best way to create a line of elevators that would solve multiple problems for anyone looking to use them. So I have a number of elevators that I use, but probably my 3 most favorite are what we call the 301, which is a straight, smaller headed elevator with a very narrow tip that could get really between the tooth and the PDL. I use those for anterior teeth and lower molars as well. I use my 77R, which is probably my workhorse when it comes to wisdom teeth. It's offset, it's a little bit wider. It has a serrated yet still very sharp, narrow edge. And then we use a spade elevator. Spade elevator is also slightly offset, bent in a little bit more of a subtle way, and it comes to a tip. All 3 of these elevators were designed with a handle that fits perfectly, that doesn't rotate in your hand, and that to understand how to use an elevator, it's really really more finesse than it is force. A lot of people think you push really hard with these elevators. Not that at all. It's used really, a lot of the action is in the tips of the fingers, where we're actually elevating the tooth from its socket by having a very, very well-made, well-constructed, well-engineered elevator that can fit into all the cracks and crevices and help you get these teeth loose so that you could just pick up your trusty forceps, pop the tooth out, make everybody happy. So as far as elevator tips and tricks, if you will, sometimes what I like to do, or really almost always what I like to do, is get as high up on the root surface as you possibly can, and using an angle that is tangential to the long axis of the tooth, actually enter between the periodontal ligament, or really the bone, you're in the periodontal ligament space, and the root surface. By doing that and just applying a little rotational force, believe it or not, most of these teeth want to come out, so they're crying for it, so help them. So one thing you really want to be careful of when you're using elevators is putting too much force on adjacent teeth or putting too much lateral force. What happens sometimes if you're trying to take out an upper third molar, if you're pushing too hard, or if you're using an elevator that's a little bit too wide, is you can actually fracture the tuberosity. This is a problem, and a lot of younger dentists and, let's say, less experienced surgeons see that quite a bit. You end up having to suture the palatal tissue or suture and repair the bone, and it's not a comfortable healing time for the patient, and it's not a good look either. So basically what you really want to do is use less force, more controlled movements, and be very, very careful. Another thing you really don't want to do is use your elevator and push against an adjacent crown. You'll avoid that to a great degree by being higher up on the root, which is something that I alluded to a little bit earlier in this conversation. But the fact of the matter is you do not want to put any pressure on adjacent crowns or adjacent restorations, because you don't want to fracture enamel or fracture an old restoration. So when I think about patient experience, my biggest thing is really to try to kind of keep the patient at ease and informed at all times. Anyone can testify to the fact that the more you know, the more calm you are about any sort of situation that you're going through. So I really do tell my patients, I kind of talk them through the experience, those that are not sedated, of course, and by virtue of doing that, they tend to feel much more at ease. Obviously, it's all in the tone of the voice and the expression of confidence, and also not being 100%, let's say, honest. Sometimes when I'm taking a tooth out, I'm telling a patient I'm testing, or sometimes when I'm making an incision, I'm just letting them know we're actually trying to assess whether or not they're numb or not. And this kind of confuses them a little bit and allows them to get through it by kind of taking them off guard. If you're telling them I'm going to grab your tooth and pull or something like that, that tends to be a little bit off-putting. So again, keeping your patients informed in an honest way, but maybe not too honest, if you know what I mean. Nothing dishonest, nothing inappropriate, but you know. So other things you really want to consider are the subtleties of the room and the noises and the sounds and things of that nature. Patients generally come into an oral surgeon or a dentist who is doing oral surgery with a certain sense of apprehension, a great deal of apprehension. Usually, certainly anxiety, fear, they're in pain, otherwise they've had uncomfortable situations in the past. In the best case, they're basically not sure of what's going to happen. So as soon as you can just make them feel that they're in the right room with the right people, you're providing the right level of care, they feel that, they know that, and that comes through. And believe it or not, making patients feel comfortable going into it will make them feel a lot more comfortable leaving the procedure.
Get more education from leading doctors like Dr. Auerbach and earn CE in the TBS community at community.tbsdental.com, or shop BloodyToothGuy instruments and kits at tbsdental.com/shop.